Hi, everyone. Welcome to today's webinar hosted by Hep B United. My name is Kate Morales. I'm the Deputy Director of Public Health at the Hepatitis B Foundation and Director of Hep B United. Today, we're going to be discussing recent research findings on the cost effectiveness and the public health and economic impact of a one-time universal screening of adults in the United States for chronic hepatitis B infection. Oops, sorry, So before we get started, I just wanted to review some tools on GoToWebinar so that you can participate. If you encounter any technical difficulties online with computer audio, please feel free to dial in using the phone option on your control panel, and the U.S. conference line is shown here. And that's going to be within your audio tab. Attendees are in listen-only mode. If you have any questions at any time during the presentation, please enter them in the question box and we'll be sure to address them as they come in and at the conclusion of the presentation. Again, if you have any technical challenges, please feel free to indicate that in the question box. Wanted to share a little bit about Hep B United. We're a national coalition dedicated to reducing the health disparities associated with hepatitis B. Our partners are working to increase awareness, screening, vaccination, and linkage to care for high-risk communities across the United States. And you can see here where different Hep B United partners are located. We're in 22 states and 29 cities, close to 50 national and local coalition members with a reach of over 1,000 local partners. If you're interested in learning more about Hep B United or would like to connect with the coalition or join the national coalition, please feel free to reach out and we'll have our contact information at the conclusion of the webinar today. And I'm going to go ahead and introduce our speaker today. We're joined by Dr. Malika Toy. Dr. Toy is an epidemiologist and instructor at Stanford University School of Medicine. Her research focuses on developing decision models, assessment of potential impact, and cost-effectiveness analysis on chronic hepatitis B infection management. She has developed decision models to help policymaking in the Netherlands, Turkey, China, and the U.S., and is continuing to develop models to help countries with their national policies in chronic hepatitis B infection control. Dr. Toy completed her PhD in public health at Erasmus University and was a Takemi Fellow at Harvard University. She also serves as a member of the World Health Organization's Strategic Information and Viral Hepatitis Modeling Reference Group. So welcome, Dr. Toy. I'm going to go ahead and give you the control.
Thank you, Kate, for the introduction, and thank you, Hep B United, for inviting me to give this talk. So I'll start off by actually sharing with you some information on what cost effectiveness is. And my presentation today will be about 20 minutes, which later we could have a Q&A session afterwards. So I work at the Asian Liver Center at Stanford University, which is the first nonprofit organization in the U.S. that addresses disproportionate high rates of chronic Hep B and liver cancer in Asians and Asian Americans. Our center addresses the gaps in the fight against Hep B through a four-pronged approach of collaboration, advocacy, research, education, and outreach. So as Kate has given some background about what I do, so I'm an instructor at the School of Medicine. I'm an epidemiologist and a medical decision scientist, so I do research on or develop mathematical tools or models to help analyze health policy problems, specifically ones for chronic Hep B treatment. I wanted to start my presentation on giving you a little bit of a background of what cost effectiveness analysis is. So in order for you to be a bit more familiarized with the study that we've done and some terms about cost effectiveness analysis. So this is a method to evaluate outcomes and costs of interventions designed to improve health. So we use cost effectiveness to help decision making or help decision makers determine how to allocate their resources. And sometimes we have, of course, depending on the type of study, we have target audiences. So these are people that we would like to influence an opinion on a subject or add the weight of information on an intervention. So in the case of today's talk or about chronic hepatitis B, we're looking at the intervention would be one-time screening, and influencing an opinion would be to get a specific recommendation out there so that some of the policy changes would happen in various settings, states, or the whole country. And these could be actually, some examples would be changing some practice guidelines that may influence by a cost effectiveness analysis. But eventually physicians and patients really do make these decisions. So even though if these guidelines or recommendations are available, physicians and patients are really, our opinion, are the real true decision makers. So how do we, so when we say cost effectiveness, so how do we actually measure effectiveness? So we call this a health effectiveness measure. It's usually expressed in terms of a unit of output. So just to give you a bit of information about, so looking at our study, the one I'm going to be presenting today, it's usually we look at QALYs, which are quality adjusted life years. Simply put, QALY is a measure of the length of quality of life gained from an intervention, which is either an intervention treatment. So one QALY is 1 year spent in perfect health. That's what we would call it. So QALY also, or utility ranges from 0 to 1. So 0 meaning very 0 meaning death, and 1 meaning a perfect health. So there are also studies that look at a number of cases detected or infections averted in various that have to do with various interventions. There are also studies that look at life years gained, and there are also disability adjusted life years. But today I just want to focus mainly on a QALY, which is a 1 year spent in perfect health. So how do we actually calculate what is cost effective and what is not? There's something called an incremental cost effectiveness ratio, which is calculated by the difference in cost between the new intervention and the comparator, divided by the difference in QALYs between new intervention and the comparator. So this is the ICER. And depending on the outcome of the ICER, and depending on which area or country we're looking at, that is how we actually sort of say that an intervention is cost saving or cost effective. So the World Health Organization defines cost effectiveness as if something costs less than 3 times GDP per capita, or something that we pay one QALY which costs less than 3 times the GDP per capita. So currently the GDP in the US is around $65,000. So if we times that by 3, we could actually, according to this definition that the WHO is giving us, that we could actually pay one healthy, perfect healthy life year, approximately $195,000. And another term that will actually also come up while I'm presenting our study is cost saving. So how do we define cost saving? Cost saving, we call something cost saving, is if a new intervention costs less and gains more QALYs versus a comparator. So in this case would be either the current practice or the status quo. So meaning that, so if we do look at a one-time screening test versus a current practice, what is happening currently? There is no screening available. And if we do have the intervention, that if the intervention costs less and gives us more healthy life years compared to the current practice, we call this cost saving. So it will save us some costs in the long term. Okay, so I would like to get into or tell you a bit more about the cost effectiveness study that we've done, which has just previously been published for the journal Clinical Infectious Diseases, where we looked at a one-time universal screening for chronic Hep B infection in adults in the US. This was done in partnership with the CDC, with a grant, with a mathematical modeling grant. So to give you a bit of background information, the NHANES 2011-2016 reports that there are around 840 to 860,000 chronic Hep B cases or numbers among adults in the US. And these, of course, range according to the age group. So we have 0.3 to all the way to 0.4 prevalence, depending on the age. And NHANES report also reports that 33% of the US population are actually unaware of their chronic Hep B infection, and that patients-related and healthcare provider-related barriers account for low screening and diagnosis rates. So the CDC, USPCTF, and the AASLD all recommend that universal HBsAg screening of pregnant women and risk-based testing of non-pregnant women. So this recommendation is actually the current recommendation. And what we aimed with this study is to actually look or to assess the economic and public health impact of a one-time universal screening of the general adult population, so 18 and above, for CHB in the US. So what we did was comparing current practice to current practice plus one-time testing to keep it very simple. And our outcomes were lifetime cost, QALYs, so healthy life years, and clinical endpoints such as cirrhosis, liver cancer, or HB-related deaths. So the methods were that we used the Markov model, where we simulated cohorts progression through a series of health states. And according to the NHANES data, HBsAg prevalence among adults 18 and above is around 0.36%. So we multiplied this 0.36% by 67%, and 67% was actually the number or the percent proportion of unaware of their infection, to obtain an estimated prevalence of 0.24, which is the undiagnosed CHB. So this is actually the prevalence that we took and simulated through a series of health states. We used disease progression estimates for the model, and that were derived from recent cohort studies and meta-analysis from North America, which came from studies that actually looked at mono-infected patients. There were two scenarios that were considered, which was a current practice versus current practice plus one-time universal hepatitis B screening. As I said earlier, we used the 33% that are currently diagnosed. We used the 36% that are linked to care, and 18% of those diagnosed are receiving treatment, according to a recent linkage to care study. So this is a Markov schematic, just to give you a little bit of information here or a visualization of what the model looks like, a simplification. So these are all various health states. So if we have somebody in a cirrhotic health state, so just also to mention, all the highlighted health states are the initial starting health states, so people can start in the inactive, active, or cirrhotic health states, and they move around. So the arrows are actually people moving from one health state to another. So here I have one example. If there's a patient in the cirrhotic health state, there's a probability of actually developing decompensated cirrhosis, which this one comes from those cohort or RCT studies, and this one is around 1.8% per year. I want to also share with you some key input variables that went into some data that went into our model. So as I told you before, that we were interested in a birth cohort or age starting at 18 and we varied this, or the range was looking at 18 to 69-year-olds. The prevalence that we used was 0.36%, the HPSAG prevalence. There was a male to female ratio where we actually assume that there is a bit of a higher a male proportion of patients in this cohort. 67% were not aware of their infection, and the eventual prevalence, the undiagnosed prevalence that we used was 0.24%. So there were various screening costs that were involved because we looked at a one-time test. We have here some of the costs of serological testing, hepatitis B surface antigen tests, which costs around $10. And then we have also a package of all 3 tests, which costs around $28. So these are all Medicare reimbursement costs. And then we also have linkage to care and treatment costs. So we have the antiviral drug cost per year, which we set at $502. And this was a combination of, or we looked both at entecavir and tenofovir here. So some of the assumptions that we did was we assumed that 60% of these patients were on generic tenofovir and 40% on generic entecavir based on a linkage to care or a claims data paper that was published last year. We adjusted these costs to 2020 US dollars using the medical consumer price index. We also assume that annual monitoring was the total cost, including biannual clinical visits and blood tests for ALT and annual HBV DNA levels, plus assuming that 50% would receive additional HCC surveillance, which consists of biannual liver ultrasound and AFP blood tests, which is recommended by the AASLD guidelines. So here I would like to share with you some of the results. So these are the clinical outcomes and cost effectiveness of a one-time universal HBsAg screening for 18 to 69-year-olds. So these are the outcomes for a population of 100,000 persons. So we see here that compared to with cirrhotic cases in current practice, compared to one-time universal screening, we actually save 7.4 cases, so there's a difference. So we could actually prevent cases. Then here we can prevent per 100,000 cases, we can prevent 10 HBV-related deaths just by introducing a one-time universal screening. And here we have the QALYs and the ICER, as I mentioned. So the ICER is actually, because the cost of current practice is higher than the cost of a one-time universal screening in the long run, so a lifetime of this cohort, our ICER, or the threshold, is actually put at cost saving. So one-time universal screening would save us money. Here is some, this is a graph of a sensitivity analysis on annual antiviral treatment. Here on the x-axis, we have the annual antiviral drug costs, and this is the ICER. So if our willingness to pay threshold is around 50,000, so that's how much we actually want to pay per QALY, which is much lower than our GDP. Our antiviral drug costs should actually be not costing more than $10,000 per patient. And here we have the incremental cost effectiveness ratio for one-time universal hepatitis B screening compared to current practice by various undiagnosed CHB prevalence. So here we have, comes close to what we looked as a baseline, or 0.24% undiagnosed. So when our test package or hepatitis B screening tests cost more, then it does mean that with this prevalence, our outcomes is actually cost saving. So if a test costs for something to be cost saving, the test should not be costing more than $10 to $13. But if we're looking at a cost effectiveness, so if we're going to pay a bit more, and if we're willing to pay $50,000 per quali, then a test could actually cost around $60 to $80. And what I've shown you when we were looking at the key input variables is that a 3-test package costs actually $28. So it's nowhere near 50 to 67,000. So it makes this one-time universal screening, even if we were to choose just only one test, surface antigen, or include all 3 tests, we're still at a cost effectiveness plane here. So as a conclusion, a one-time universal screening of the US population ages 18 to 69 years for CHB is cost saving and will result in better health outcomes with reduction in cases such as cirrhosis, liver cancer, liver transplantations, and HB-related deaths. And based on this, hopefully a national recommendation for universal CHB screening beyond pregnant women will greatly simplify the screening process and can be readily included in the electronic medical record system for all adults on the one-time hepatitis B test. Thank you. And now I can take some questions.
Thank you so much, Dr. Toy. And wanted to remind the audience, if you have any questions, please feel free to enter them in the question box at this point. And also the handouts for this paper is available. You should be able to download those from your control panel, as well as another paper that was recently published by the same research team. And I can get us started. Let me pull up my slides. So if you had mentioned that we were hoping for a one-time, or not a one-time, but a universal hepatitis B screening recommendation, which I believe is being considered by the CDC at this point. And if that were to be recommended for all adults, in your opinion, what do you think are some key strategies in terms of implementation of a universal screening recommendation, especially to overcome some of the known barriers on both the healthcare provider and the patient population?
Yeah, thanks for your question, Kate. Well, so we actually did this study as a background information, or to get sort of a backup for CDC to recommend this policy, or to recommend a one-time universal screening for adults in the US. And this was to actually simplify. So currently, what the primary care providers actually are doing or need to be looking at so we're looking at high risk groups that need screening. And most of the time, these physicians actually do not know whether some patients a country of birth, or whether they really do come from a high risk group, whether they're migrant or not. This is not included in the medical records. So this one-time screening would make it would simplify things. And how this can be implemented, well, this surely cannot be implemented overnight. It will be a process to so both physicians and patients. So one thing that does come to mind, one thing that has been discussed, is perhaps that lab test, there will be an automatic that once a patient does come into for consultation, or when the physician does order labs, that Hep B testing or HBsAg is immediately clicked, so it saves the physician time and the patient time as well. And perhaps also something that when this does become recommended, people will hear more about it in the media or in the news, that they could actually ask their physicians for such a test. So hopefully these are things but we are hoping that this will be, the electronic medical record is something that hopefully this will be picked up and it will go more smoothly. Yeah.
Yeah, great, thank you. Um, yeah, we're hoping that that is really interesting that if we're able to include it in the lab in the lab test, and that kind of takes away that step for providers. Um, um, do you think there are any lessons learned from hepatitis C, knowing that there is currently, a more recently as well, universal screening recommendation that we can take away?
Yeah, definitely. I do think that there are some lessons to be learned from hepatitis C. Whether this is for screening or whether it's for also treatment, but it seemed like the guidelines that were prepared by the CDC or recommendation for hepatitis C screening did go smoothly. So there's hopefully the same thing will happen with Hep B, and this can be when this finally is recommended, it will actually be the uptake will increase, or testing, at least diagnosis rate. So as you've seen when I presented, or the type of studies that we use, so diagnosis rate is around 33% for hepatitis B currently, which is very low. As well as people being treated, or the linkage to care, which from a claim study, that's around 36%, and people being treated, that's also around 18%. So these are all very low compared to what's been happening past years for Hep C when the guidelines were implemented. So hopefully there will be also ways for us to measure once this is being recommended. Yeah, but we could measure and see if this uptake will be higher.
Yes. So I had a question come in from the audience, and I'm going to summarize it. So the study looked at a one-time surface antigen test, correct? And the question is, if you looked at whether a full panel would be, if that were to be offered, so looking at immunity as well, and if someone who needed a vaccine, the hepatitis B vaccine, whether that was incorporated into your model. Do you want to talk a little bit about that?
Sure.
Knowing that also that there may be a universal vaccination recommendation in the pipeline as well.
Right, definitely. That's actually a great question. We, with this study, since we only focus on a one-time test or one-time screening, we've also actually looked at linkage to care and treatment, which was a combination. What we did not do with this study is look at vaccination for the general population. So we did not look at, so one of our health states was not a susceptible health states where people also would be susceptible or would be tested for whether they're surface antigen negative and they'd be actually receiving a vaccination. So next, our next study will be focusing on that. So we've already started working on the model to look at that. That's a good question. What we did look with this study, or some of our results or in our publication, what we do show is we looked at a sensitivity analysis. So even though we did not look at susceptibility or vaccination, we did look at what if a physician does order the 3-panel test, so as a package. So when you look at the costs, so the surface antigen Medicare costs are $10 per test. When we order a 3-panel test, all 3 tests, it's around $28. So when we used our sensitivity analysis, when we did include all 3 tests, our outcome is actually cost saving or cost effective. So it still falls under the cost effectiveness area, let's say.
Right.
Yeah.
Okay, great. That's great to know. Thank you. And I think the follow-up question, which I think you might, if you're looking at this, I think in your next paper, whether the cost effectiveness of the test would be affected by the prevalence of vaccinated in population, I guess.
Yes, yes, definitely. Those are important. So we did not include it in this study since we were the aim of the study was just to look at one-time universal screening or recommendation of a test. But we're definitely looking into that and including that in our next, in our next.
Great. Great. So another question we have is, can you speak to the cost effectiveness of a universal screening of the general population compared to high-risk populations, for example, pregnant women, intravenous drug users, etc.?
Yeah, so up to now, it has all in the U.S. I think that the current testing recommendations were always for either high-risk groups or pregnant women. And what the CDC has actually asked us to do was whether it would be cost effective to actually just test everyone ages 18 and above, so adults in the US. And technically, whether or logistic that would simplify things and whether it would actually be cost saving or cost effectiveness compared to a high risk population. So with this study, we actually conclude that it is, and it will actually also simplify the screening process, let's say. So whether we don't have to always just focus on the high risk population or the pregnant woman, but we could actually just introduce a non-invasive one-time test to see whether, somebody does need some of the long term, if somebody tests positive, whether they'd be eligible for treatment. And that's how the modeling actually, that's how we've done look at the long term. So if we have to test, if we have to get a one positive test out of 360 people who do test negative, it's still worth doing this because we do save a lot of money in the long term and also save lives. And that's what our study sort of tried to show, that yes, until now it was always being focused on the high risk population or on pregnant women specifically. But with this study, we want to show that it's actually possible to also do that for the general population with a very non-invasive one-time blood test. Yeah. A very low cost, and especially since the treatment is also very, and the reason why this is our results are cost saving or very cost effective are because treatment costs have dropped by a lot, and that actually also helps to at this moment to actually have this whole one-time universal testing and treating afterwards for it to be cost saving or cost effective.
Right, right. Speaking of treatment, and we're assuming generics, everything. So speaking of treatment, I know you have another paper recently. Do you want to just share a little bit about that?
Yeah, we actually looked at, so one of our papers is recently, so last week just came out. We've actually done, I mean, this was about 1.5 or 2 years of our time that were put into developing a mathematical model to look at a potential cost of a cure for hepatitis B. Well, I mean, it's a hypothetical study. There is not yet a cure for Hep B, but there are a lot of definitions, or there's a talk, and there are a lot of lab or a lot of scientific tests or randomized control trials out there that are focusing on this. So what we looked at is a potential functional cure, and a sort of compared that to the current practice. So what would a functional cure, if there were to be one, how much would that be costing for the population, for it to be cost saving or cost effective for the populations in the US, in Australia, and in China. So this was a study in collaboration with a few centers where we gathered some data on current antiviral treatment costs and current linkage to care and treatment rates, as well as diagnosis rates in each of these countries, and where we looked at a hypothetical either 30%, 50%, or 90% effective cure, and what would that look like in the population. And we actually conclude that even if we have a 30% effective cure compared to a current antiviral therapy, for it to be cost saving in the US, it would need to be costing not more than around $20,000, $23,000. So that's a whole lot less than when Hep C cure came out some years ago, which came at a cost of $90,000. And the reason why we actually did this study was hopefully a cure will come out soon for Hep B, and well, we were interested in a threshold, how much that would needing to cost for the population to be able to make use of it, let's say, for it to be cost saving for the government or for insurance companies, etc. Yeah.
And hopefully affordable.
And yes, definitely, and accessible. Yeah. That's another question.
Accessible.
Yeah,
absolutely. Thanks for sharing. This is so important to have. There's been very limited, cost effectiveness studies within the hepatitis B space. So we're really grateful that you and your team have contributed to the body of knowledge around this topic. I guess, looking to see if there's any other questions related to the study. And I guess one to wrap up is, if you addressed this earlier, has this been implemented? And I think this person might just be asking from overseas, or is it under review? Do you want to share anything? And I can add to what I know too about.
Yeah. So has this been implemented as in
I guess the universal recommendation, I think.
Oh, okay.
My interpretation.
I think not yet. I believe that CDC is still writing or putting a report together, so hopefully soon. Yeah, but the paper did come out about a month ago, so that's new. Yeah.
Yes. Great. Thanks for that question. Yeah, that's what I'm aware of too. The CDC is currently undergoing, review of it, and like Dr. Toy said, preparing, looking at the evidence, continuing to look at the evidence, and preparing a report. And we're hoping to have a decision or a draft to look at by early 2022, I believe. So not too far away. All right. Any additional questions related to the studies? Okay. So if not, we will go ahead and wrap up. So Dr. Toy, thank you again so much for sharing your research findings with us today. Like I said, it's super exciting to have this data available, especially for when we are making the case for increased resources dedicated to the elimination of hepatitis B in the U.S. So we're really grateful and appreciate your research. And thank you everyone for joining today. Thanks for your time. I heard that there was a national alert, so hopefully that did not interrupt you. I didn't get it, but thanks for joining today. There were questions about sharing the slides. So yes, the slides will be available. It will be posted on our website, and we will also be sending out a copy to everyone who has joined today or registered, along with a copy of the webinar recording. So please feel free to share that, as well as the handouts that were disseminated today. And then as you exit the webinar, please do share feedback. There will be a short survey once you exit out, and follow up. Let us know if there are any topics that you're interested in hearing more about in the future, as well as feedback on today's webinar. All right, so have a great day, everyone. Thank you, Dr. Toy.
Thank you.